discuss the etiology, clinical features, investigations, and management of reactive arthritis. Reiter syndrome. The term reactive arthritis refers to an arthritis that is associated with recent or coexisting extra-articular infection, usually gastrointestinal or genitourinary infections. Reiter syndrome refers to the triad of reactive arthritis, urethritis, and conjunctivitis. Etiology: gastrointestinal infections, Salmonella, Shigella, Campylobacter, and Yersinia. Genitourinary infections, Chlamydia, Neisseria gonorrhoeae. Genetic predisposition: the prevalence of the HLA-B27 allele in patients is 63 to 96% versus 6 to 15% in healthy white controls, thus supporting a genetic predisposition. Clinical features: reactive arthritis commonly affects young men aged 16 to 35 years. However, it may occur at any age. Presentation is usually acute onset oligoarthritis affecting the large and small joints of the lower limbs 1 to 3 weeks following sexual exposure or an attack of dysentery. Symptoms and signs of urethritis or conjunctivitis may be minimal or absent, and there may be no clear history of prior dysentery. Extra-articular features are Achilles tendonitis, plantar fasciitis, cercinate balanitis, keratoderma blennorrhagica, nail dystrophy, and buccal ulcers. Cercinate balanitis is superficial erosion in a circular pattern on the coronal margin of the glans penis. Keratoderma blennorrhagica are hyperkeratotic skin lesions with desquamating margins. Systemic features like fever, fatigue, weight loss can occur. Investigations: ESR and CRP are raised, normocytic normochromic anemia, synovial fluid analysis shows features of inflammation such as low viscosity, turbid appearance, and presence of giant macrophages, Reiter's cells. Urine culture may grow Neisseria gonorrhoeae or chlamydia. Stool culture may grow the causative organism but are usually negative by the time arthritis develops. Serologic testing: detection of antibodies against the organism may help confirm previous dysentery. Rheumatoid factor and ANA are negative. Radiographic features: initially there are no changes. With chronic disease, periarticular osteopenia, joint space narrowing, and marginal proliferative erosions may develop. Periostitis, especially of metatarsals, phalanges, and pelvis, and large fluffy calcaneal spurs may be seen. Asymmetrical or unilateral sacroiliitis and syndesmophytes can occur. Management: NSAIDs control the pain and inflammation of the arthritis. Steroids, intraarticular or local corticosteroids injections are helpful in relieving the symptoms of arthritis and or enthesitis. Systemic steroids are used for anterior uveitis. Anti-rheumatic drugs, sulfasalazine, has been shown to be effective in reactive arthritis. Azathioprine or methotrexate may be required in severe progressive arthritis, and intractable keratoderma blenorigica. Antibiotics are used to treat acute infection. Chlamydial urethritis is treated with doxycycline.